start with you.
Good morning, dear Marcia. Thank you for your kind introduction. I have no conflicts of interest to declare. Conservative treatment of deep vein thrombosis is mainly based on three columns, I would say. Anticoagulation, compression, and mobilization. And these are the points which I would like to go through with you. I would start with anticoagulation, and I will keep my presentation very pragmatic, not showing any details from numerous randomized controlled trials, but just in accordance with the CHEST recommendation, the recent one, which you heard from Andrew already, more details, and the other one is the international consensus statement chaired by Andrew Nicolaides, which will come out next year. So all what I'm going to tell you is at least in accordance with these two recommendations. Start with anticoagulation immediately after diagnosis. Immediately is very important in patients with high clinical suspicion while awaiting the results of diagnostic tests. This is very important. This is the Friday afternoon thrombosis or the Saturday thrombosis. No access to any investigations. You need to start immediately with full dose anticoagulation. And this is mainly based on low molecular weight heparin in therapeutic dose. Therapeutic dose is very important because still some people mix it up with prophylactic dosage. You need to read the leaflet in your package which you have, and the therapeutic doses are in average 3 times higher compared to the prophylactic doses. And you start with vitamin K antagonists, for instance, macroma or warfarin, on the same first day. Then you continue anticoagulation, you check INR initially daily, and when the INR target range, which is between 2 and 3, is reached, you don't stop low molecular weight heparin, but you go on with low molecular weight heparin plus oral anticoagulation, and only when the INR is between 2 and 3 for 2 days at least, only then you can discontinue low molecular weight heparin. And this low molecular weight heparin should be given for at least for 5 days or longer. As we heard, there are some proposals to keep it longer, and continue with oral anticoagulation for at least 3 months in average. In case of cancer, you would not switch to oral anticoagulation, but you would continue low molecular weight heparin for 3 to 6 months. And also during pregnancy, low molecular weight heparin is, of course, the treatment of choice, no oral anticoagulation throughout the pregnancy and for the first 6 weeks after delivery. Concerning the duration of anticoagulation therapy, at least 3 months long in patients with a major provoking risk factor, what we called secondary deep vein thrombosis previously, and an INR check every 1 to 3 months is sufficient. In unprovoked cases, where we don't know an underlying risk factor, the duration of anticoagulation therapy may be indefinite. So the last recommendations are rather promoting prolonged anticoagulation, always considering the balance of benefit and harm, bleeding, and the patient's preference. And periodic reconsiderations is recommended. So in unprovoked DVT, as long as possible, so to say. The same applies to recurrent venous thromboembolism. Also in this case, you would give indefinite anticoagulation therapy. After completing 3 to 12 months of conventional anticoagulation, some new compounds may be considered. You will hear about that in the next presentation from Andrew. Concerning home therapy, we heard already from Andrew, there is a clear recommendation that in those patients whose home circumstances are adequate, we recommend initial treatment at home over treatment in hospital. Also, after catheter thrombolysis, you should apply the same system of treating giving anticoagulation in the same intensity and duration as in comparable patients who do not undergo thrombosis removal. And the second part is compression mobilization. And for compression, we may start with bandages or stockings, and we should try to keep people mobile and to make them walking. And this is still a kind of concern why I put patients with acute deep vein thrombosis into bed. When the patient comes in, he has already pulmonary embolism. If you look at it, you find it in most cases. So this is really a thromboembolic disease, and the aim of therapy is to prevent the growth of the clot. And to prevent the growth of the clot in an ambulant situation is much more effective than if you put the patient into bed by increasing stasis. So if you see such a patient coming in, let's say he's 66 years old, has a history of 10 days, what is your first question? My first question would be, when have you been up for the last time? And if he tells you he lies in bed, but he goes to the toilet, he is not bedridden, and you should keep him mobile. Compression and walking, this is what the ACC guideline 2008 tells us, immediate mobilization with stockings to be worn for at least 2 years at an ankle pressure of 30 to 40 leads to a more rapid reduction of pain and swelling and reduces the occurrence of PTS. So this is not only because the PTS is reduced later, but also it's helpful to reduce the pain and the swelling in the acute stage, and that's important. Should we take bandages or stockings? We made a randomized controlled trial comparing these two facilities, and the results concerning edema is shown in this slide. You see bed rest, nearly no reduction of edema in 9 days, bed rest at that time. Stocking and Unna-Boot bandages very strongly applied inelastic material was much and statistically significantly superior. Unna-Boot bandages in the last days was significantly better than stockings. And the same applies to pain reduction. We had here the visual analog scale and the so-called Lowenberg difference. And you see the best results are coming from the bandage compared to the stockings. However, we were very surprised that the stockings also in the acute stage of deep vein thrombosis are very effective concerning pain reduction and swelling reduction. The problem is that you need to prescribe a new pair after the initial phase because they would be too loose. This is my last slide showing a symbol which was created by our Joseph II, the Emperor of Enlightenment, when he wanted to educate his military surgeons. At that time, the military surgeons were trained in barber shops, so to say, and he wanted to combine the medical knowledge symbolized by the Aesculaps rod with the sign of the surgeon, the skill and experience of surgeons. This is the hand with an eye which is able to see what the hand does. So this is a very meaningful symbol for surgery. Medicine and surgery, science and experience, in unione salus, so the combination of both is important for the patient. And thinking about Virchow's triad, we should always not only concentrate on anticoagulation, but never forget also the important stasis factor. Because as a matter of fact, you know that stasis, bed rest, sitting, long standing, is the main trigger for the development of deep vein thrombosis. So don't forget Virchow's triad, and don't forget antistasis measures, and not only concentrate on anticoagulation. Thank you for your attention.